Hello and welcome to Pain in the Podcass, your place to find out everything you've ever wanted to know about pain. My name's Dr. Joseph Parsons, and I'm joined by the wonderful Don Wigesoria and Dr. Joshua Craw. And today, we're going to be talking about language and pain, part 2. Welcome in.
Hello and welcome to Pain in the Podcast. This is part 2 of our episode on language and pain. If you've not seen part 1, please make your way back and have a listen to that first. It was very enlightening.
Yes, indeed.
This episode is going to start as we start all episodes. It's about what we've learned about ourselves and facts about ourselves too. So, Joe, would you like to start us off?
Yes, please. My fact about myself is that I was once the subject with my university housemates of a wanted poster at Newcastle University. But it wasn't us that was on the picture. The criminals were wanted, but what was on the picture was a pumpkin.
You were a pumpkin?
No. In first year of university on Halloween, we were leaving our halls of residence and someone had put a pumpkin that they'd carved just like out on the big field that was in front of the halls. And one of my friends suggested to me that we should play rugby with said pumpkin. So we were like throwing it. I don't think we had intention to break the pumpkin, but we were like passing it to each other and whatever. And then like the pumpkin smashed when we dropped it, basically. So the pumpkin just shattered in the field. But what was funny was that the next day, and I mean like by the time we'd woken up maybe like 10 o'clock the next morning, and it'd been like 11 p.m. when we'd been playing the rugby, 10 o'clock the next morning there were printed posters all over this halls of residence saying like wanted the murderers of, I can't remember what it was called, but it had a human name. It's like Stephen
Stephen the Pumpkin.
Stephen the Pumpkin. And they had pictures from multiple angles of Stephen the Pumpkin, so they'd obviously prepared in advance.
They were very proud of that pumpkin.
They were very... It wasn't particularly good, it just had like eyes and a smile.
You've just destroyed their entire world.
I know. So if anyone is still wondering who was guilty of the pumpkin destruction, it was myself.
We have the culprit here.
Myself and my uni colleagues.
Fusing Castleese is circa 2015.
Yeah.
That was a shithole.
It was. It was actually designed to be a women's prison, but then they decided that they had enough occupancy at other prisons, so they would repurpose it into student halls, which is why the sinks are still bolted to the wall so that you can't escape underneath.
Aren't all sinks bolted to the wall?
No, as in like you don't have a cupboard underneath your sink.
What?
The
thing that stands.
The thing that's the cupboard. No. The sink is attached to the wall, but also the bit around the sink where you'd usually have a cupboard. There was no cupboard.
There's cupboards around sinks? Wait, I just got what you meant.
Yeah, it doesn't always have to be
cupboards.
Yes, yeah,
Right.
exactly. So the bits when you have like a work surface around the sink and stuff under the sink, it had that, but you couldn't get into it. It was bolted to the wall to prevent you from digging through where there was pipe work and maybe more vulnerability
So
in the walls.
you couldn't open the cupboard?
There was no cupboard. It looked like a cupboard, but had no doors and no way of getting through. It was just wood bolted to the wall in order to make sure that you couldn't dig through the weak points where the pipes went.
See, Josh went to the same university and was in the same halls.
On the same
flat.
hallway.
Yeah. So to you, it makes perfect sense. But to me, as someone who was only there on like one drunken night, it makes no sense. But now things are coming back to me and I am able to put the pieces together.
I'll give further context. We had a friend who was on this podcast, Mr. Ollie Stewart. His bedroom, he'd open his curtains and there was just a brick wall.
It was honestly, if you had to imagine like the ideal conditions to create vitamin D deficiency, it was like he would open his curtains and he was going into a hallway. Like it was like an alleyway between two buildings. So Josh is not exaggerating. 3 feet from his window was a brick wall with no access to light. So he'd get up in the morning and be like, what a beautiful day. Pull his curtains back and it's still pitch black.
And it just had a sink in the middle of his room as well.
It was really, really tragic.
Grim.
Yeah. He survived though. He survived long enough to make it on the podcast. So
just
it was
about,
a win.
yeah. So my fact about me this week is something that probably nobody else knows, but I only ever keep 2 pairs of shoes on the go at one time.
On the go? What do you mean on the go?
As in on his feet?
No, I've only got 2 pairs of shoes.
So he's wearing 4 shoes.
Exactly. 2 on the hands, baby.
Yeah, I've only got 2 pairs of shoes.
I don't understand.
How many pairs of shoes do you have, Don?
About 22.
Joe, how many pairs of shoes do you have?
Probably, like, including, like, sports shoes, like basketball and stuff, probably, like, 10.
I have
dance shoes,
No,
actually.
that's-
No, like,
no.
15 more.
Yeah, because I'm including all my like sports specific shoes and stuff.
I have 2 pairs of shoes.
Ever. So when you get a new pair of shoes, do you just decide which one you're going to sacrifice?
I just wear them until the can't be worn anymore.
Are we including slippers, like house slippers?
Wait, but one of your pairs is hiking shoes, and one of your pairs is smart shoes.
I don't have any smart shoes anymore.
Do you not? Have you worn them through?
Worn them through, so yeah.
Wow.
They're
So
out
what have you
for
got at the
a
minute? You've got a pair of hiking boots.
and a pair of trainers.
Wow. So when you go to my wedding later in the year,
Hiking boots.
okay.
Unless I wear through the trainers, then I might get some smart shoes.
Okay.
Yeah, it is in the countryside.
Exactly. You can't really tell. They look sensible.
Yeah.
I might rent a pair of shoes then, just for Joe's wedding.
my God.
can
But
see
I
the
will
look.
have to pawn one of my pairs, so I only have 2 at any one time.
How do you feel about renting shoes?
Weird.
Do you go
Slightly
bowling?
weird, right? Yes, and I used to love those shoes. Like they were so slippery and slidey.
Love what?
Bowling shoes.
Bowling shoes, not because I
bowling
didn't think
shoes.
I was too young to think about the disgustingness that was inside of them. I
But
just
Don, they've sprayed them with
They were
what appears to be deodorant. So that
it was
must
the
mean
best
it's fine.
smell. I can't. I've been longing for that smell ever since. Like they don't have those smells anymore. The sprays because you
Oh,
don't
the spray. Okay.
because you don't. You can just wear your own shoes nowadays.
Not
bowling
feet.
alleys. Feet.
It makes me wonder.
Feet.
Was it
Smell of feet.
The
That's
no,
not the fit. That's
not
not the
the
smell you miss.
No.
It makes me wonder why they made us like rent out those shoes.
Yeah.
Is it extra money?
No, well, supposedly it's meant to be so you don't mark the surfaces, isn't it?
I think it's bullshit. Is what it is.
Almost certainly, but
COVID. Thank you.
was it COVID that they did it for?
No. They stopped doing that. They stopped
what I
making
mean.
it mandatory at COVID. Yeah. So
Wow.
after COVID, you can wear your own shoes. Well, that's what it was at like our local bowling alley.
That's so interesting. You know, when you look back and you think, how will COVID have permanently changed the world? And a lot of stuff has gone back to similar to what it was before, but bowling enthusiasts will never be the same. They
Hot
probably
damn.
buy their own shoes, don't they?
Yeah.
Either way, right. Firing the question at you now, Don. What's your fact about yourself this week?
So my fact is that I have always known what a cheese string was, but I've never had one, and so today I have had one. Thank you, Josh, for supplying that. It was, delicious.
It's just cheese.
It's just cheese. as Joe was saying.
cheese.
It's just about cheese.
It depends how you say that. We were talking about this earlier on when Don first tried it. The way in which you say their slogan, "It's just cheese," really changes the meaning of. It determines whether it's cheese that is fair, cheese that is only just classable as cheese, or it's 100% cheese.
Do you think cheese strings are the UK equivalent of like cheese in a can from America?
Yes.
I really want to try cheese in a can.
I really want to try cheese in a can as well.
I have no.
Why is it so yellow?
What's it called? Cheese whiz, is it?
I don't know enough
That's
about
Oh,
it.
cheese whiz! Do you reckon that's where it comes
Cheese
from?
whizzikers.
You're thinking of Gee Whiz.
Gee whiz, no, I know, but do you reckon that's why they call it cheese whiz? It's because it sounds a bit like gee whiz.
Maybe. Oh, well, let's get into some more etymology, shall we? No.
Just for context there, from the editing, you won't have got how far apart that was. We just spent like 2 minutes just kind of Googling away
In silence.
in silence for Josh to go, no. It does not come from gee whiz. Okay, shall I talk about my learning for this week?
Please do.
I have learned that I have a very low tolerance for people who take long pauses in their sentences while editing. So I have been editing episode 13 of the podcast today, or possibly episode 14, I can't remember.
An episode.
An episode of the podcast. And one of our guests, Ollie Stewart, decided that just to make my life a living hell, he would take like a 1.5 second pause in the middle of most sentences, which meant that I just needed to go through and snip out a ton of dead space. So, yeah, that I found out I had low tolerance for that.
Ollie, you've been called out. Go get some help.
You've been called out twice this episode.
Ollie, you've been called out. That was what I had to deal with. Either way, so that's what I've learned. I've got poor tolerance for editing.
And my learning for this week is, well, as a doctor, exams don't just stop. You continue to do exams even after you've graduated. I've been a doctor for now 3 years at the time of filming, and I'm doing some professional postgraduate exams. And learning this week is just how much I've forgotten how to actually study.
I think you have to study studying. How do you study studying?
Well,
How do you
what I
study?
mean is, I've forgotten how to study.
So what does your current routine look like?
I don't have a routine. That's the
I
problem.
think that's your problem.
Exactly. Like, joking a test before when I was like up to 10 years ago when I first started university, I could just sit and spend 10 hours revising solidly, like in the focus zone. Just now, after working 50 hours a week, having other commitments as well, it's just so difficult. I just can't do it.
I think you probably could study with that same intensity if you didn't have so many other responsibilities. That's the problem with being a doctor in sort of training for specialty, is that junior doctor is incredibly difficult, specialty training is incredibly difficult, and I'm sure consultancy is difficult as well. You just never really have the time to dedicate to doing that study, so you're kind of just trying to fit it into the cracks, basically.
Yeah, and I'd forgotten so much.
Also, it's just absolutely exhausting having to maintain that high level of functioning for so long and then expect to do more from yourself.
Well, that's it, yeah. There's a thing called the forgetting curve, which is the longer you leave something, the more you forget. But if you sort of do little and often, then you don't forget. Well, yeah, doctors fall into the trap of not doing that little and often, and then getting to exams and being like, oh, I need to really properly revise now.
But the problem is, I think, when you get to like an end of a medical degree or sort of any kind of any really like long period of education, you feel like your brain is at its point of being full. But then in this case, you're expected not only to top up the information that you already have and keep it sort of at that level, but you're expected to add to that in your career as well. So it's like you feel like your pint glass is already full, your information bank is already full, and you have to not only maintain everything in there, but fill it somehow as well. So it's like, it feels like there's no more bandwidth left to give, basically. So relearning this stuff, I don't know, are you forgetting things in order to learn this again? Like, is it forcing other information out?
Yeah, it's a bit like Homer Simpson. Every time I learn something, something else goes out, eh?
Yeah, exactly.
And after you saying that and me understanding and acknowledging that you said that, I have now forgotten what my thing was.
Okay, Homer. Ironically, he was talking about Homer in the last part of this episode.
We were.
That's right, that's right.
Have you remember what you've learned about yourself?
Yes, I have. And I think it relates more to what your thing was, Joe.
Okay.
The lack of tolerance. And my lack of tolerance is for people on TV, on reality TV shows.
Okay.
So my housemate and I, he kind of gets me into these reality TV shows, and he has pointed out how quick I am to judge these poor people. And I need to control that. I'm an adult. I shouldn't have these judgments on other adults and other people. It's wrong. And I need to just accept that and embrace the show for what it is and not be quick to judge.
What show is it? Come on.
You got to tell us now.
I actually don't know the name of it. Let me just look it up.
Love is Blind.
It's not Love is Blind.
Don is blind.
I am blind. So the TV show, the reality show, was Virgin Island.
Oh, God. Oh, I heard about this on
It is
Twitter.
where 12 courageous adult virgins embark on a unique intimacy course at a luxury retreat to overcome their anxiety.
I mean, in a sense.
But this my lack of tolerance to these individuals doesn't just pertain to this show. It's for most reality shows.
Yeah. I can't say I'm a big reality TV fan.
No, I'm usually just subjected to it.
Yeah.
Forced.
Yes.
My a skill I really want to develop is being able to read while there's lots of background noise. So whenever my mum didn't like a TV show, she's just so good at zoning out and reading that she can just sit there and read a book even when there's like loud noises going on around her. But this reached a point where you'd be like wanting to ask her a question about something else. You'd be like, "Oh, Mum, you know that I'm going out to whatever this person's house today," and she'd be like, "Yeah," and you're like, "What did I just say, Mum? Mum? Mum! Oh, sorry, I wasn't listening to you." No, I could tell you weren't listening to me. So I want to develop that prowess.
I'm so jealous of you, Mum. I wish I could do that.
Yeah. So when we're subjected to reality TV, if we could just fully zone out and focus on something else.
That is very close to complete mindfulness.
It is.
And, sneak peek.
Ooh. Right, shall we get on with today's episode?
Let's do let's.
Let's do that.
So we ended last episode talking about how we describe pain, about how language can really impact the way that we feel it, including the adjectives that we use to describe pain. Now I think what we need to do is have a look at communication and pain.
Yeah.
So not just the words that we use, but how we communicate it as a whole.
So I want to start maybe kicking off by thinking about how sort of private or public pain is. So there's a famous philosopher called Ludwig Wittgenstein, and he argued that pain cannot be a private experience because then we'd never be able to learn anything about it through the scientific method if it was truly private. So basically, we couldn't know anything about pain as a collective. We couldn't understand, like, the qualities of pain. We couldn't understand what causes pain and what doesn't if it was a truly private experience. So he says you wouldn't be able to attach labels to any pain sensations. It has to be shared understanding of pain and a sort of public feeling of pain that allows you to actually kind of process it. So I'm interested to know what you guys think, whether you feel like pain is truly private or whether you think we build kind of a cultural feeling around pain.
That's a very good question. I think that pain is a private thing in terms of my pain might feel very different to what your pain feels like. However, I do feel like we try to build communities around it more so. So we see people going to groups for chronic pain. We see people bonding over sort of different types of pain, be it chronic fatigue, be it fibromyalgia, arthritis, that sort of thing. So I feel like, and although yes, maybe as an individual, it is an individualistic thing, this pain. It's what's happening to you, not other people.
Yeah.
But we try to make it a community. I think what Wittgenstein was saying there pretty much is how difficult it is to empiricize things, to how to say, okay, this is ones and zeros, how can we study this and make it very uniform?
Yeah.
Which is difficult, particularly when pain is such, as we know from all the episodes that we've done here, how subjective pain can be between people.
Yeah.
And there is no very obvious focus for pain. We've talked about noxious stimulus, we've talked about the neurotransmitters, we've talked about the neurological pathways, but individually, does that make a difference?
I think you kind of hit the nail on the head there, Josh. I wouldn't quite go as to say that we should normalize discussing pain. I think it depends on each individual's comfort levels when it comes to that, because I think it gets to a point where there's inevitably going to be enough people who are comfortable to talk about it and who do go out and search those communities where they can discuss their pain, such as the ones you just mentioned, Josh. And then through that, we're able to gather enough information about what that's like. But I don't think everyone has to subscribe to that. I think they can just pick and choose if they want to share it and discuss it or not. I think normalizing the fact that we should talk about it, I wouldn't go as far as saying that. I think it just depends on each individual's comfort levels when it comes to that.
I can see where you're coming from, but I fundamentally disagree.
Oh.
I think that we should be opening things up to talking about them. We find that when people are more open about other things, for example, mental health, that it reduces stigma. Like, stigma is such a big issue with pain, because as we were talking about this, pain's such an individual aspect. It can lead to disability, it can lead to social withdrawal, it can lead to completely changing your character in terms of it's your defining feature. So without being able to openly talk about it, how can we break those stigmas? How can we educate people that maybe aren't necessarily having such a big issue with pain? Now, obviously, we can't force that on people. If somebody wants to be very stoic, if they want to just deal with themselves, I agree, absolutely done. We don't need to push people that way. But I feel like, as a whole, as a society, it's something that we do need to talk about more.
Yeah, because I think this all boils down to the fact that we all of us have grown up in a very kind of empiricist society, and we spoke about this in previous episodes. Empiricism is this idea that there must be a biological cause if there's pain. There must be something that we can link the pain to. And as we all know from, at least from my experience, I think Don's and Josh's causes of their pain is more well understood. But for me personally, they don't really know why my back is painful. But because we've got this empiricist society, it means that the patient narrative, how they communicate their pain, how they understand it, has basically become noise. It's seen as a distraction from the healing process. It's that what you're saying doesn't matter. We should be looking for the biological cause of this and targeting it. And I think Josh is right. If we're going to get towards a more healthy culture about communicating our pain, we need to move away from this empiricist system and encourage people that their narrative, their story, is a valuable part of the sort of management process.
And I completely agree. I think encouraging that would only empower people to speak up more about it. But I don't think that. I think it just depends on their comfort levels at the end of the day.
Absolutely.
It's just about each individual's comfort levels. The more people who do share, the better. Yes, of course. But there are certain people who just don't want to share.
Do you know what I think the biggest value is for? Because I agree with you on that. In that point, it's got to be everyone's choice about how much they want to share publicly. But I think the biggest benefit of people sharing their own story and their ways of communicating their pain is that it teaches other people how they might want to communicate their pain. So you might see a metaphor that someone uses and it really strikes a chord with you. But the reason in particular why I think empowering people to find alternative ways of describing their pain. Stella Bullo, back to the researcher we spoke about with endometriosis last episode, who works in sort of endometriosis and language, she found that women who describe themselves as having difficulty describing their pain in the early stages had an average 9.7 year wait for diagnosis, whereas those that felt that they could describe their condition in the early stages only had a 7.4 year wait to diagnosis. I say only, I'm aware that's still far, far too long, but if you imagine that just struggling to communicate your pain adds another 2 years onto how long it takes you to get a diagnosis and treatment.
Well, yeah, I mean, it's almost like, 20-25% decrease in the time waited.
Exactly.
So as a doctor, Josh, as a medical professional, do you feel that some patients are just hesitant or lack that confidence in bringing this up or bringing up the right kind of terminology, metaphors, whatever it may be?
I think, talking from being a doctor in the UK, I think there are multiple it's a multifactorial issue. Is it with patients describing their symptoms properly? It's definitely contributing. Is it to do with pathways that we have within the NHS, within healthcare systems that make it difficult for us to get to a definitive diagnosis? I'm thinking in terms of waiting lists, time waiting for scans, missed appointments, that sort of thing. What may be contributing to this, where we see such a decrease in time waiting to get a diagnosis, if you're very proactive about your symptoms, if you continue to present, if you're very something is wrong, and it's not just cramps. I need a diagnosis. I need to be investigated.
Yeah.
I think that has a big part about it. And I am absolutely 100% for patient advocacy. That's why we have, particularly in the NHS, is you have a right to a second opinion. If you've seen a doctor who you feel hasn't maybe investigated or hasn't been as thorough as what you'd like, you do have the ability to get a second opinion. I think that is important.
Do you think then that these people who are getting diagnosed earlier, not only do they describe it better in terms of communicating their pain, but do you reckon that's an overall better level of communication? The way you described it made it sound like maybe these people have more assertive communication styles, they get their message across better, and just as a result of being a better communicator generally, that then empowers them to communicate their pain better.
But one thing I'd like to bring up there, Joe, is I think it's kind of to be a better communicator, I think most people are better educated as well. And so if they're more educated, they know what kind of things to look out for, what to expect, and what to, I don't want to say demand, but what they're
you're
owed.
right, though.
100%. Don is onto an absolute winner there. What he said is that if you're from a well-educated background, if you're from a more affluent area, you're going to be better able to communicate to somebody who is a doctor. I'm a working class background doctor. I come from an incredibly poor family, but the majority of doctors, 96% of them, come from middle class to upper middle class backgrounds. So they've learned to converse, to communicate in a specific way. So that definitely has an impact. Not just that. If you're less educated, this isn't a throw at people who haven't been to university, but if you're from a poorer area, if you come from, let's just stereotype this actually. Myself, I'm from a poor Yorkshire community up in the north. Less likely for me to go to university, less likely for the people I went to school to go to university or be more highly educated. And you've got the postcode lottery as well. These areas are chronically underfunded. So we're talking about, okay, there's a delay in getting a diagnosis. Well, if you're from a poorer area where you're not able to get an MRI scan as quickly, where the waiting lists are longer, where the burden of care actually is for preventative medicine, for example, if smoking is such a big issue and COPD in people in their 40s, so COPD being a chronic lung issue, typically linked to smoking, if that's a bigger issue than endometriosis or chronic pain, it's going to get prioritised. That's going to lead to delays.
Yeah.
So actually, I agree with Don. Education, I think, has a big impact on communication and how we access healthcare.
Also, based on just going back on what you said about postcode lottery, rich people can afford private healthcare. Does that mean that the residents of those areas share less of the NHS with their neighbours? Does that make sense?
Yeah, so that's actually a good point. It actually takes burden away from the NHS. So I've seen, particularly when I was in medical school...
But just in those areas?
So if you're wealthy enough to get Bupa or whatever private healthcare provider that you want within the UK, yeah, you're taking pressure off the list of the NHS. So that does help from that point of view. Now, if I was a GP and I got a patient who has hip pain or knee pain and they want to go for an operation, if they can afford to go private, I think quality of life wise, I may even suggest that. Now, I'm not telling anybody here on Pain in the Podcast that they need to go private to get things done. The NHS does work, but it's a bit slower.
Thinking about the NHS and kind of harking it back to communication there, Rudyard Kipling, the famous author, once said...
Not the person who makes the cakes.
No, same guy. Still alive, baking every day. That's why he doesn't write anymore. He's not dead, he's just baking constantly. He once said, words are, of course, the most powerful drug used by mankind. And I think we've spoken a lot about how we as people with pain use language to communicate with clinicians, but I think maybe it's worth understanding how the language that clinicians use impacts our pain.
Okay, yeah. And do we have any studies or anything about that?
Yeah, I mean, Pain Australia, I think, they're an organisation. They give what I think is probably the best set of guidelines to clinicians about working with people with chronic pain.
Of course they did. They were the ones who made the game Dumb Ways to Die.
Yeah, good.
Actually, well, not Pain Australia, but the Australian government. So I know they're great at making these informational resources.
True.
Yeah.
They say that when you're communicating with people, try to make sure that chronic pain is not made the defining aspect of their life. So when you're working with someone with fibromyalgia, understand that there's more to their life than that. When you're treating them, you're not just aiming to treat fibromyalgia, you're aiming to improve that person's overall quality of life, to help them get back to what they want to be doing, to help them achieve their goals. Don't fall into the trap of communicating with a patient as if they are their disease.
But that's really difficult from the medical professional's perspective, I feel like, because not a lot of patients go to these appointments and say, oh yeah, this is what I do for a living, this is what I do at my weekends, I want to treat this pain so I can go back to doing that.
We should be asking those questions as clinicians.
You should be.
Should be. You're meant to take a social history that involves understanding what the patient's goals, expectations, priorities.
And are patients comfortable sharing that?
Typically, yeah.
Generally, yeah.
Yeah, I mean, I was clerking patients last weekend. So for people that don't know, when somebody gets admitted into hospital, you do a clerking, history, examination, talk about social history, medications, all of that. And I had a gentleman that came in with shortness of breath, but we talked about how he plays golf 3 times a week, how he goes to the gym still. That's very important information, particularly in the older generation, because it tells me how active he is. It tells me what his priorities are, and that actually, in terms of active management, we need to be more active in that.
Yeah.
I think some of the issues surrounding the Australian guidelines is that doctors are very much labelling patients by their disease.
Yeah.
So I've heard clinicians say, "Oh, we've got another wheezer," which is somebody with asthma, for example.
And also a band.
And also, I looked at you and I was like, say it.
Yeah. So, we've got that's the NOF patient, so neck or femur fracture, those sorts of things. So very much defined.
I don't have a band for that one.
Yeah. So
Femur.
So very much defining patients by their illness or comorbidities as opposed to who they are holistically.
Yeah. I think though, when we're using sort of terminology around patients, one of the things that the Australian guidelines suggest is that you need to be respectful and adhere to the sort of terminology that the patient uses. And they recommend in their guidelines avoiding terms like patient and sufferer and victim and especially attention seeker. But you know what? For me personally, when I started experiencing chronic pain, the term sufferer was still very, very common. And I like it. I know most people won't agree with me, but I would call myself a chronic pain sufferer. I live with chronic pain. There's this kind of shift towards saying that people aren't, that they are someone with a condition, rather than saying a diabetic, it is a person with diabetes. And I get that shift, but like, I do suffer with chronic pain. I live a great life despite it. But there is still suffering involved. The pain is what produces the suffering. So I think that their advice about adhering to the terminology the patient wants, I would want my clinician to kind of align with that. I don't want them to tell me off for calling myself a sufferer.
I think a counterpoint to that is, I think knowing you for as long as I've known you, I'd say you've got a good head on your shoulders. And so you are able to identify if you were playing the victim role.
Sure.
Some people, I don't know if some people are capable of detecting that for themselves. I think because their pain is so intense and so strong and takes up so much of their lives, they do kind of fall victim to it sometimes, and they're not able to recognize that for themselves. Yeah.
It's like an inadvertent becoming a victim.
Yes.
They're not trying to play the victim, but inadvertently it becomes who they are.
Exactly.
And it victimizes them.
Exactly. And so when those kinds of individuals start using that terminology and the doctors are able to pick up on that, would it be right for them to continue to use that kind of language?
Yeah, I'm with you. But again, I think it's the clinicians being respectful of what your choices of language are, isn't it? That's what it all boils down to.
So you're saying, if I said, my neck, my back, my pussy and my crack hurts, you have to say it that exact same way.
I'd say it the exact same way.
And I would respect you for it.
Thank you. Josh, as the qualified clinician in the room, I'll be there soon. Hooray.
Woohoo!
Ow. What other advice would you give to clinicians when trying to get across sort of like tips for communicating with patients in pain?
Yeah, I'm a northerner. I talk in plain sentences. When I'm talking to a patient, I try to talk in very patient-friendly language. You know, I think there was a Stewart and Loftus in 2018 actually came up with a suggested words to use for clinicians, rather than using the medical terms, rather than using the jargon. So, for example, an effusion. That's just another way of saying swelling. I wouldn't use. I might say, yeah, there's a joint effusion, but that means there's swelling, fluid around a joint, for example. Instead of disease, you can go say condition. Instead of bulge or herniation, you can say lump or swelling. A trapped nerve, you know, it's tight and it can't be stretched. These are all different sort of terminologies that we can use. And like, instead of bone on bone, you could say narrowing. Now, I actually disagree with this one. I like to say bone on bone. 1 second,
Josh. What does either of those two things mean?
Yeah, so let's say that somebody's got osteoarthritis. We see that one of the very common signs of that is loss of joint space.
Mm-hmm. Yeah.
So if I use my hands and make an action saying, look, your knee is effectively, normally it has a nice cushion on it, we call that cartilage.
What Josh is doing right now for you listeners is putting his knuckles together.
So what we say is, yeah, normally you have a nice cushion on it, either meniscus, either cartilage.
Fluid.
That makes things move nice and slow. with wear and tear, that can get degraded until it's just bone on bone, which is what can be the cause of some pain.
So that's narrowing.
Yeah, the joint space is narrowed. So there was fluid and meniscus and other tissue that made a cushion. And then when that cushion is lost, the bone comes closer together. So the space between the bones narrows.
And so why do you disagree with that?
Because I prefer to use the term bone on bone.
Right, okay.
For me personally, every patient I've seen either on placement or when working as a therapy assistant, whenever they use bone on bone, they assume that there's absolutely nothing that can be done to help their situation. That's the reason why I kind of push back and try to use things like narrowing, or why I just describe it as arthritic changes. Because when people have it in their head that this is over, my pain will never get better, it's bone on bone, I'm destroying my joint, I think you take someone by the hand and you lead them towards catastrophizing. That's how it feels to me. So
narrowing, I think I agree with you there. Narrowing has more of a hopeful tone to it.
Exactly, like it's narrowed, but it's not the end of the world.
It's
There's
still
stuff
an
we
ing.
can do.
It's not going to get better by itself.
It won't, but the thing is that you can still improve people functionally, you can improve their quality of life. The joint itself may not get better, but you can reduce the pain.
What a lot of people, when they've been diagnosed with conditions, is they're not necessarily looking for the potential of it being cured, but they also just want the reassurance that it won't get much worse, or it's not at its final, like, later stage. So narrowing kind of ticks those boxes because it's something that's still actively happening, and so
how does the patient know that what narrowing means in terms of?
Because you're explaining it to them.
Yeah,
which is why I like to use bone on bone.
Yeah,
but bone on bone, it's still it seems like the last resort.
because you're not going to go through the bone.
Yeah,
you could fracture things, but the patient, as far as they're concerned,
if that was your point, if that was what you wanted to get across, then yes, I get why you'd want to use that. But I think Joe has a good point where narrowing just seems a bit more hopeful.
You don't want to make it seem terminal, as in final, to the patient.
That's the word I was looking for, terminal, yeah.
Either way. But you can see what's nice in this episode, I think, obviously, usually we toe the party line here a bit at Pain in the Podcast. We have our sort of a lot of shared opinions, but language, as you can see, like there's been a few times during this episode where you've seen that we don't sort of align in our ideas around pain and linguistics. And that's really nice, actually, because it gives you that idea that everyone's communication is personal, and especially for the clinicians out there listening, encouraging you to find the communication style that works for the patient in front of you, encouraging them to share with you how they like to communicate so you can kind of get on their wavelength and make sure that you're working towards the same goals. Because someone might be like you, Josh, they might think, I don't want you to sort of beat around the bush. If bone is contacting bone, I want you to tell me exactly how it is. Yeah. Whereas other people might say, well, actually, that makes it feel final or whatever. So I think it's actually a good thing that we have the kind of...
if there's a difference between the two in terms of severity, then yes, use whichever is more appropriate.
Sure.
Does that help?
Yeah. But one last thing as well, when thinking about clinical interactions with pain patients, back to our favourite person of the last two episodes, Stella Bullo. She wrote another paper in 2021 about endometriosis, and in particular thinking about women's experiences when going into clinical settings and that challenge of communicating. Women with endometriosis tend to feel that clinicians rushed them, that they discourage them from talking about their symptoms, so they kind of try to lead them away from describing their symptoms, and that they try to normalise their experience. And so by normalise, they're belittling it. They're effectively saying, oh, it's just period pain, or, a lot of women experience this. And I think that's one of the things clinicians need to be very careful of when they're communicating with people, is make sure that you're not trying to just lump someone in. Understand these people are an individual, listen to their own description of their pain. Don't try and, just because they have endometriosis, for example, doesn't mean that they'll present like every other person with endometriosis. Like, let them communicate their experiences. Don't put them into a box just because of their condition.
Yeah, absolutely. I can't disagree with you, Joe.
All right, so now we're going to go back to languages and see how the way that we talk differs from language to language.
Interesting.
Obviously it differs because they're different languages, but I mean specifically in terms of pain.
Yeah. I actually had a chat with a friend from Romania about this. I asked him if there were any kind of interesting phrases relating to pain. And he had like an interesting point to make about Romanian culture. And he said that there's this phrase in Romanian which I'm going to see if I can cut him into the episode here saying it, because just with the accents and letters that I don't usually see next to one another, I'm going to get this dramatically wrong. So this phrase
Mă doare sufletul.
would be translated into it pains my soul, rather than it pains my heart. So in Romanian, they choose to have an influence on something paining the soul because of the influence of the Orthodox Church. So rather than actually having this kind of, we think about the heart as being this centre of like tugging on the heartstrings, etc. But when they have a pain, they say it pains my soul.
That's really interesting, yeah. It shows that the influence of language in the past and how it's functioning now, yeah.
Yeah.
Another one that Alex mentioned was...
Mă doare în cot.
which translates to "it pains me in the elbow." And what they mean to say about that, or what Alex said that they mean to say about that, is that they don't care about something. Is that right, Joe?
So it pains me in the elbow means I don't care.
Yeah.
Okay, interesting.
Is that because when things hurt in the elbow, they're kind of... No, wait, that's not right. Because I was going to say when things hurt in the elbow, they're kind of brushed off. And like disregarded sometimes. You know, like a funny bone.
Yeah.
Like when you hit your funny bone, it's just like, you've hit your funny bone. Just calm down.
No.
I don't care. No?
No,
Okay.
I don't think so. I don't know where it comes from.
I'm just trying to make sense of this. It doesn't quite make sense to me.
No. But it is interesting that like how these phrases around pain develop in different languages. What's really interesting, though, when you think about different languages, there's a paper that I hinted at the beginning of the last episode by Maya Ponsonnet and colleagues, and they basically looked at verbal interjections. So what that means is...
Oh, sorry, Joe, can I just cut you off there? Sorry.
Oh, that is very good. I hadn't realised that. I just looked furious at him when we were recording. No. Interjections, yes. So she looked at things like pain, disgust. So imagine that you see something disgusting. What noise do you make?
Ew.
Ew. But they compared sort of different sensations. So one of them was pain, one of them was disgust. They looked at a couple of others. But they found that across 130 different languages worldwide, there's very, very similar vowel sounds in all of the interjections for pain. So things like ow.
Ching, tang, whoa, bim, bang.
Things like ow, ouch, ah, aye. There's that kind of mouth shape that's involved in saying all of these. And it was far more commonly shared, this kind of vowel sound, than in any of the other sentiments. So disgust didn't have anywhere near the same level of kind of consistency. And so what they suggest in this paper is that possibly this is a form of language that develops inherently within us, so that pain, just as humans, makes us make a noise like that, and we create our own versions depending on language. But she's basically suggesting that rather than us creating words to associate with a feeling, in this case it's actually the other way around, that pain created the words.
Ooh.
That's interesting, because I've just thought maybe it goes the other way around as well. So maybe more positive words came about with more positive emotions. So if you take happy, for example, you can't really say it angrily, can you? Try it.
I hope you're happy.
I guess you can.
That's pretty good.
You got me there. But like with the mouth shape that we mentioned earlier, happy.
Yeah, it
happy,
kind of...
like at the end you're kind of smiling, no?
No, it's like when people say German's really aggressive. It's only aggressive because you say it aggressively.
Yeah.
Same with Arabic, yeah.
It's the way in which it's said.
Yeah.
Yeah. Yeah, so I just think it's really interesting that this is sort of so consistent across languages, and that it may be a word that rather than us creating as humans, that the word kind of created itself.
Yeah, it's in our blood.
That's
Wait, isn't that how language works?
Well, no, we choose words.
Do
Whereas
we?
she's saying that this sensation forced a noise out of us.
No, we
that-
choose words after they've already been derived from something else.
Yes, but original language, the first time we ever used language as humans,
Phonation.
Yes.
we went, that thing over there, tree, and we made the word tree into a tree, right? The word tree
How
didn't...
do you know that someone didn't just run into that thing and was like, tree?
So you think that every word that exists is created by people hurting themselves on that object?
I mean, how do you know that?
Pain is the source of all words. But there's one last kind of thing we want to talk about in terms of different languages and pain, and is a study by Morgan Gianola, and you're actually going to hear an interview where he talks about this a little bit more. But he looked at Spanish-English bilingual individuals, and he basically found, in a very, very, very simplified version that Morgan will go into more detail of, is that the same stimulus is more painful in Spanish than in English.
I think I know why. I mean, you're going to give me the more scientific reason with Morgan, but my reason is Spanish is just much more of an emotive language.
Could be. That is, you'll hear when Morgan talks about his theories for why this is.
I don't know if this is just a stereotype, but it was more of a parody of the stereotype. And so it was a video, I can't remember the source. If I can find it, I'll put it on the show notes. But it was about Latin Americans and their kind of... So when they were switching between thinking in Spanish and thinking in English, they found themselves they would complain about things and vent to their family, friends a lot more in Spanish than they would in English. And that kind of expression was more intense in Spanish than in English. So I think that's kind of what's happening here. Because Spanish is such an emotive language that it's very similar with pain.
Well, let's find out, shall we? Let's hear from Morgan now. So, I am joined today by Morgan Gianola, a postdoctoral researcher at the University of California in San Diego. He gained his PhD at the University of Miami, and for his dissertation work, he studied the influence of ethnicity, culture, and language on health outcomes. And he's with us today because he wrote one of the most interesting studies that we've ever read while researching for this podcast. He looked at bilingual individuals and tested how language and culture can impact their perception of pain. And he found that the same painful stimulus might feel more intense if a bilingual person experiences it in a Spanish-speaking context compared to an English-speaking one. But he'll give a far better summary than me. So welcome, Morgan, and can you tell us a bit more about your work?
Yeah, thank you for having me, Joe. I'm very happy to be here. So I'm happy to sort of go as fine-grained or as sort of broad picture as you'd like. I guess kind of a very general overview is just that we had people come in who were Spanish-English bilinguals. This was in the context of Miami, so everyone was Hispanic, Latino, of various sort of ethnic backgrounds. And we had them receive these painful heat stimulations while they were in an MRI scanner. So we were collecting functional brain images, which is so an MRI takes a picture of your brain. That's an anatomical MRI. It gives a really good fine grain, here's what the brain looks like, here's what the structure is. And then a functional MRI is basically like doing a video. So it's what areas are active at different times. And what we were interested in seeing is what areas were responding to the pain. And we did this while they were receiving these painful heat stimulations in a context where they were speaking, thinking in English, and then also speaking, thinking in Spanish. And we did this sort of separately in two blocks. Some people started in English, some people started in Spanish, but everybody did both conditions. And we were basically just looking at what are the differences in how they rate the pain, how does it feel? And then what are the differences in their brain activity while they're getting pain in these different contexts?
So what were the kind of key findings? So like I mentioned in that introduction, it seems that people might feel a more intense stimulus when they're in that Spanish-speaking context. But were there any changes in that brain activation that linked with that?
Yeah, so a couple of caveats on this first. This is very new research. We had a sample that was moderately sized for a neuroimaging study. But these things need to be replicated to have strong confidence in them. Overall, so with just their pain ratings, we found that there was that people tended to rate the pain as more intense in Spanish versus English overall, but there was an interaction with their cultural orientation. So what I mean by that is we had them complete a bunch of surveys that sort of asked them about what language do you tend to use in different contexts? What's your preference? How well do you sort of relate to Hispanic culture, and what Hispanic meant for a given individual, like depended on their ethnicity. So we're in Miami, there were a lot of Cubans, there was a lot of Colombians, Venezuelans, so it sort of depended. But anyway, how strongly they sort of identify with that side of their cultural identity versus the quote unquote US American side of their identity. And what we found is like the extent to which the language affected their perception of pain was related to this measure of like how strongly they identified with each culture. And we did a behavioral version of the study beforehand. So that was kind of the same overall process, but not in the MRI scanner. And we were seeing that like if you identified more strongly with the Hispanic side of your culture, you would tend to rate the pain as more intense in Spanish. But if you identified more strongly with the US American side of your culture, you would tend to rate the pain as more intense in English. And we saw sort of a trend to that same pattern with the brain imaging study. But it was like there was still overall everybody on average rated the pain as more intense in Spanish, but the people who were more identified with the Hispanic side of their culture had a bigger effect, basically. The difference between the English ratings of pain in the English context and ratings of pain in the Spanish context were larger, depending on how strongly they identified with that side of their culture.
Yeah, I mean, it's just phenomenally interesting that this would have an effect. And I guess this is going to be the impossible question for you, the $1 million question. Have you got any theories as to why this might be, that sort of different languages can alter how intensely a stimulus is perceived?
Yeah, so I will say I had a number of working hypotheses before, like when I was just designing the study, and even like the first behavioral iteration of things. I sort of thought like, okay, there's literature on what's called linguistic relativity, like the way that we think about and habitually describe different experiences might affect the way that we perceive them. And I sort of thought like, okay, there's a number of sort of grammatical, structural differences between English and Spanish that might lead to differences in the way you're describing pain. Like you might sort of emphasize the temporary nature of the experience, because these are induced painful stimulations. These are people living with chronic pain. This is, healthy volunteers who are getting these heat stimulations. It's like, okay, it's painful for a moment, but I might, when I describe it, in English, you would just say like, okay, this pain is going on. It is happening, and that is the same for like, I am a human being, or I'm wearing a red shirt. Like both of those are the same thing.
Sure.
But in Spanish, that would be described differently. Like the verb you use to say I'm wearing a red shirt is different than the thing you'd use to say like I'm a human being. And so you might be sort of emphasizing that like temporary nature of the experience that might lead it to be a little less intense, or maybe you're sort of like more connected to it. Anyway, I'm sort of going off on a tangent because that's actually not what we found. What we found is that it's not just like, okay, one language is always more intense than the other isn't. It's that it had this interaction with the cultural identity. And so my sort of working theory about that is maybe it's kind of having to do with like, okay, if you identify more strongly with one layer, maybe that's the one you're kind of habitually perceiving the world in. And so when you're filtering the pain experience through the other language, it's kind of like serving this like translation filter where you're not experiencing it as directly. So like, okay, rather than just like I'm feeling this painful experience and it's just like with me, I'm like passing that through a layer of like, okay, but how do I describe it in this other language that I'm like not sort of as habitually tuned to? That was kind of my thought about it before we did the neuroimaging study. And then the neuroimaging study gave us a little bit more insight about maybe what's going on. Again, all the caveats about small samples, replication, all this stuff. So trying to get at this, I sort of hypothesized 3 different mechanisms. Either they're sort of just describing the pain differently, but it's actually perceived kind of the same. You just like give it a lower rating just in the way you talk about it, which might be related to sort of just like language-based activity in the brain. It might be you're attending to the pain more sort of consciously or more strongly in one language or another, and that would be related to, you know, different brain areas that are related to directing attention. Or it might be that just the stimulus itself kind of feels stronger, that there's, you know, more activity in those direct like sensory processing areas when you're getting the painful stimulation in one context versus another. And you know, I kind of would have hypothesized more the language or the attention factors would be driving it. And we did see a little bit of evidence for that, but the strongest effects we saw were actually in those like direct somatosensory processing areas. So like the activity in the brain, just when you have a sensory experience of feeling something, and that could be both painful and not painful, there's this part of the brain that's responding, and it has sort of a map of the body. And the area related to the arm where they were getting the stimulations had higher activity in response to those heat stimulations in the given language context, and that mapped on like very directly to their pain ratings. So it's sort of, this is the relationship. As you had higher activity in that somatosensory area for a given language, that also predicted how big the differences in your pain ratings would be across the two languages. Wow. So it does seem that there really is like sort of a direct experience of like feeling it more strongly, which is why I kind of ended up on this thought about like the sort of filtering of the experience. Like you're getting it more directly when you're using the language that you kind of like identify, feel more connected to.
Yeah. So it's almost like a filter layer. It is being in your less confident language. It's sticking a filter over it and kind of maybe not numbing the sensation, but it's putting a blur on it almost. Yeah,
exactly. The way I think of it is, yeah, maybe that blur, like it's passing through another step rather than just being as directly experienced. It's like you're taking that experience and trying to put it into other terms. And in that process, it's almost like a distraction from the direct sensory experience itself.
Amazing. Yeah, I really can't wait to see what comes next in your work, and I can't wait to see how sort of other people progress in this field, and we'll of course share with anyone listening sort of how Morgan's work goes on. And yeah, thank you so much again for coming on today.
Yeah, no, definitely. I'm happy to share it if people have follow-up questions or are interested in knowing more. I'm happy to have people reach out as well.
Thank you so much. Cheers.
Oh, that was a very interesting interview, Joe. I particularly found interest in the parts about the fMRI, or the functional MRI, and how actually the way that different languages can affect different areas of the brain. That can cause like remodeling, neuroplasticity, and it can affect the flow of blood to different areas of the brain. So it does sort of point towards that language can affect the brain differently.
Yeah.
In terms of pain.
I mean, there's actually a couple of studies that we found that show that when looking at chronic headache patients versus healthy individuals, they took 20 people with chronic headache and 20 people who were generally healthy, and they looked at pain-related sentences being read to them versus non-pain-related sentences. And at the same time as this, they applied a pain stimulus. So I think in this case it was a heat stimulus. So they give you a small like hot probe, jab you in the arm, and see how you respond to it. And they found that actually the pain-related sentences increased the pain intensity that people felt. So having this association of pain not only with the feeling of it, but with the language that's being used with you at the same time, it seemed to induce a higher pain sensation. Ooh, okay. So imagine that I poke you with a hot stick of metal, and I say,
Tree.
Yeah, I say tree. It's very unlikely to sort of trigger more of a pain response. Whereas if I sort of do the same thing, but I say sharp knives at the same time, you're more likely to associate that kind of pain-related term with higher pain intensities.
Fluffy bunnies.
Exactly. Probably going to be a little bit nicer. But it's interesting, and there was a study in 2010 called Do Words Hurt? And they found that areas of the brain called the inferior parietal gyrus, the precuneus, and the dorsolateral prefrontal cortex were more activated in response to pain-related words. And these are all regions that are associated with pain processing. So actually these areas are getting switched on more just by the words themselves. That study didn't even have a pain stimulus. It was just looking at which areas get switched on in response to pain-related words.
So it's almost like your brain's priming you to feel pain.
Precisely. Which again might be, harking back to the last episode, the guy who had the nail in his boot. Maybe the reason why he felt pain was his brain had preconditioned him given the situation. Okay, that was a visual cue rather than a verbal one, but his brain had already told him there was going to be pain, and so whether or not there was, kind of primed a greater pain sensation.
Moving on to the final section of our episode this week is Don, our in-house poetry master. We've not heard much about his poetry and his slam poetry for a while, so would you like to introduce this section for us, Don?
Gladly, because I'm actually not going to be reciting any poetry. Instead, I'm going to hand the torch to Joe, because he has written this unbelievably beautiful poem, which I think we can all kind of resonate with. So, Joe, take it away.
And I'm going to pass the book to Josh. No, I'm kidding. Yeah, this is something that I wrote when it was back at the sort of midpoint of COVID, and I was at a very low ebb of my pain journey. And hopefully this is something that people will resonate with. Will it last, my body? Will it last to have a family? Will it last or fall apart quickly? To describe the feeling of imminent implosion, the sentiment of joint erosion, when positive thoughts cannot be chosen, as the thunderclouds in your brain have frozen, and it's one tap, one knock away from shattering, and my God, it's shattering. Every second of every day flattening, and the tears like raindrops pattering as the frozen mess that was once your head thaws, drips, and shorts the batteries. Language doesn't stretch. You can't shape the words to fit your pain. You can't shape your body back right again. Not a word that could describe the fear that this is it then. This is as good as it gets. Enjoy the spiral downwards, it's almost like a bobsled. You'll never run again. No word can fit the feeling that you might not see your 30th year in, but there's no visible reason for the pain that's seething, so my default stance is not believing. And my God, I just want someone to believe it. I want someone who understands that it feels like at times I can't survive this, but with no intention of taking my life. It's a feeling like one day you might just slip on over to the other side. Your body got fed up, but it really tried to fix itself time and again, to suppress the pain, to help keep the distress at bay, but it's cyclical and I'll end up fine again. And today will be another day that I overreacted, and I'll end up not fine again, and I'll worry that this time it will remain protracted. And I won't make it to my wedding, and I won't make it to see my kids, and I won't run again, there'll be no fun again, and this is all there is.
That was beautiful, Joe.
Thank you.
I feel like maybe we should have had you do slam poetry instead of Don.
Fuck you, Josh.
No, Don was very good. Don is the true poetry delivery expert, but the reason we wanted to kind of finish on that was language is obviously really important for you communicating your pain to clinicians, to people around you, to loved ones, but sometimes language can be a really good outlet, and so looking for opportunities to write about your pain, to share it with others. I think we've all benefited at times from using our pain to inspire creative outlets, hence Pain in the Podcast. But it's something worth trying. Like if you're kind of running out of ideas about what to do to help manage your pain, then does no harm to try and find a way to vent and get it out on paper.
I mean, we were able to find each other and understand each other's pains, so you can definitely find that sense of community if you do want to reach out. And if you do want to find that sense of community yourself, we'll put some links in the show notes below to some peer support groups that you can find in your local areas.
Yes.
So reach out and
Please
find
do.
some people, like-minded people who you can share your thoughts and pains with.
And to finish off, I guess we'll do our book review and we'll love you and leave you.
Absolutely.
Today we are looking at The Pain Habit by Drew Coverdale. Very mixed feelings about this book. It has some really useful information about how you can use mindset changes in order to kind of change your view on the world and on your pain to try and cope better with the pain, have better quality of life. But there are bits where it does feel like it's gaslighting you for being in pain and that the pain is kind of your fault. It's like you've thought yourself into pain is kind of the attitude that it gives sometimes. So, mid-table for a book, I would say.
Pretty mid.
Yeah, I wouldn't go out of your way to buy it. But equally, I wouldn't say it's terrible. I think you just have to take some of it with a pinch of salt and just make sure that you don't go into it thinking that it's going to fix you.
Or make you feel better about yourself.
That too.
So it doesn't quite belong in the skibbity toilet, but it does have a bit of Riz and it's a bit mid, so it's not quite Sigma, but it's quite Alpha. I don't know what the last two ones are. I think I got them mixed up. But
I think you did
you
great.
get my point.
I think everyone listening can tell that we are definitely down with those kids.
We are so Gen Z.
We are.
Wait, are they Gen Z?
No, they're
Gen
younger.
Alpha?
Probably beta now, I don't fucking know.
I don't know.
Young.
What year was X?
Yeah. Josh is a boomer, actually. Josh was part of the baby boom after the Napoleonic Wars. But something we didn't let you know about last episode, just before we go, is our Patreon.
Yes.
Where you can find a written version of Joe's poem.
That is true. You can find the written version of the poem. You can find some other poems slammed by Don from our 20-hour challenge.
And more importantly, you get to watch our breakdown.
You do get to watch our breakdown.
Each of us individually break down.
I've had multiple breakdowns.
We've actually after this episode you'll be able to hear our 19th breakdown. We break down each episode the week after the episode, so you get to hear a little bit more in-depth facts about what we've done, a little bit more about our mistakes, about the things that we would have done differently, the things that we've learned about ourselves, tons more about us, loads and loads and loads of bonus content, and it all helped to keep us paying for the train fares and the petrol to make this podcast.
It's a lot, you guys.
So
No,
much.
sorry, no, that sounds like I'm needy. I am, but I don't want to sound it.
And on that note, go listen to next episode of The Breakdown next week if you are on our Patreon, and if not, we will see you for the next episode in 2 weeks' time.
Goodbye.
Ciao.